Teresa, are you going to get us started this morning? Great. Good morning, everyone.
Morning. So we can go ahead and kick things off. Thank you everyone for joining our webinar today, Plotting Your Course for Collaborative Care Implementation. Next slide. Thank you for joining us. If you're not familiar with the Association of Cancer Care Centers, ACCC is an organization that helps translate clinical findings and administrative findings into how-to. We're a large community represented in our membership of over 1,700 private practices, hospitals, large health systems across the country. We are also multidisciplinary. We have about 40,000+ practitioners, from research administrators, clinical practitioners, financial advocates, and support staff. We would also like to thank our partners for this webinar, the Association of Oncology Social Work, AOSW, and the American Psychosocial Oncology Society, APOS, for their support and input on this presentation.
Well, thank you so much, everyone. I just wanted to start out with just a really warm welcome and thank you for being here today. We're so grateful for your time, your curiosity, and your shared commitment to improving the lives of patients and care partners impacted by cancer. Your presence reflects a collective belief that supportive care is not an extra, but that it's an essential part of quality care. So thanks for being here. I want to take just a moment to briefly introduce the panel here. We have Dr. Bill Pirl, who's the chair of Department of Psychiatry and Behavioral Health Sciences at Memorial Sloan Kettering. We have Dr. Jesse Fann, who's the medical director of psycho-oncology at Fred Hutch Cancer Center and professor at the University of Washington. And Courtney Bitts, who is a senior director, Division of Social Work in the Department of Supportive Oncology at the Dana-Farber Cancer Institute. Next slide. Thank you. Next slide. So here today, our conversation is really here to center on collaborative care, an evidence-based model that elevates how we support patients and the people who walk alongside them. By working across disciplines and centering care on real human needs, collaborative care strengthens outcomes, deepens connections, and enhances a practice of supportive care with everyone involved. It's a model where serious consideration as we continue to evolve our practices and to meet patients and care partners where they are with compassion, coordination, and intention. I also want to say that this webinar series, next slide, and accompanying resources are focusing on really turning collaborative care into action. We'll explore practical ways to implement this evidence-based model in your own facility, leveraging the strengths of your existing team, how you do the work, workflows. While many of you may be approached by outside companies offering programs or interventions, this focus is going to be how you can build and sustain internally care that is tailored to your patients and their care partners. Our goal is to share realistic, actionable strategies that help embed collaborative care into everyday practice in meaningful and lasting ways. So here are some other resources. Next slide. And I think what's amazing is this is just one of a big part, and even more exciting of these upcoming other webinars. Next slide is there are going to be office hours. So I think at the end of these, we have so many questions. There's going to be opportunity for you to just call, ask questions. So with no further ado, I'd like to pass it over, next slide, to Dr. Pirl. Thank you.
Hi, thank you, Krista. And so we're dividing up this talk, and I'm going to be talking about increasing awareness in buy-in. And as we're doing this webinar series with ACCC at Memorial Sloan Kettering, my institution, we're actually planning pilots of the collaborative care model that we're going to be launching later this year. And I am providing sort of real-time, step-by-step postings of what we're doing. So you're welcome to connect with me on LinkedIn and follow along with me providing a lot of detail for each of the steps. Some of the stuff we'll be talking about today, and you'll get to see how our process is unfolding, and hopefully you might be able to use that as a guide for your own decision-making processes. Next slide. So when you are trying to increase awareness, I think the main thing is to realize that most people have no idea what collaborative care is. They've heard the words collaborative, they've heard different types of care saying that they're collaborative care, but no one really understands what it is. People will sometimes think that collaborative care is only an intervention for depression, since that's what some of the research papers are. And some people have ideas of what collaborative care doesn't do. What collaborative care is, it's a care delivery system. Collaborative care doesn't specify who your client should be. It doesn't specify what type of care you should be delivering. It's a care delivery system which allows you to tailor it to meet the needs of the population that you're serving. Collaborative care also helps. Collaborative care will address, I think, a lot of the psychosocial needs, but you will still need to have some specialized services. And collaborative care is a great way of systematically making sure that your population gets connected to those services. It's probably one of the best ways of making sure that patients get the right care at the right time by the right people, which we like to say in psychosocial oncology. It's a way to systematically do that. And I'll give you some ways of talking about it on the next slide to try to increase people's awareness of it. There's strength in numbers. So as you're trying to increase awareness in wherever you are about it, getting different allies who may be from different disciplines to help spread the message. It's good to focus on the advantage and the evidence at the beginning and not get bogged down in detailed descriptions of the processes. That's been a mistake that I think I've made many times, of starting off with, here's all the different ways that we'll do this, and here's the system. People can't really hear that. People want to know, like, what are the advantages of this and what's the evidence? You also need to really tailor your messaging for specific stakeholders. Everyone is going to be wanting something different or wanting to hear different things about what this might do for them or how this might impact them. And rather than watering it down for everyone, I think coming up with tailored messaging to the different stakeholder groups is necessary. And as you're trying to increase awareness and buy-in, it's not trying to have everyone say, we're going to adopt this across our entire center and do this for the rest of our lives. It really is just getting to the point of, can we do a pilot in this? Like, that's really your goal at this point, of getting people to know enough about this, to be interested enough about this, to try a pilot. Next slide. So here are some scripts for initial messaging. As you're talking about collaborative care, here are some lines that you could use. Collaborative care is a highly coordinated, team-based stepped care that increases access, improves outcomes, and is more financially sustainable. Collaborative care delivers better care to more patients at lower cost, is a nice, succinct way of describing it. A selling point is saying, like, when evaluating whether to adopt a new practice in healthcare, people ask if it's better, faster, or cheaper than what we're doing now. Collaborative care is all three of those. And then lastly, really focusing on why you may need to change. And I think a good line for that is, our current model of mental health was never designed for ready access for high volumes of patients. We need a new model. Next slide. A good analogy for this, I think, is the phone booth. Collaborative care is, in order to get people ready for change for collaborative care, it really is focusing on, we need a different system. We do have interventions that work. We do have people who can deliver this care, but we need a new system to deliver it. A phone booth used to be a system to be able to communicate with people. However, phone booths were never designed for high volumes of people to have ready access to communication. when they're put in those situations, you get long lines and waits, which we all know about in our psychosocial oncology clinics, which weren't built for high volumes of people. Or if you try to, next slide, if you try to force too many people into the system, it really loses its functionality. If you try to put too many patients to see a therapist, like you're really not able to, like in the phone booth, you're not able to make a phone call on that phone booth or actually communicate. You lose your ability to provide effective treatment. And I would say the way we're doing psychosocial services now are really a mix of both of these. And collaborative care is a different type of framework for delivering services, which can help us do this in a way that is more sustainable. Next slide. As people are not that aware of the collaborative care model, I think it's good to do some level setting and legitimization of the model where you are. I think one of the best ways to do this would be having a grand rounds or a special talk from an external speaker, of someone coming in and reviewing all of the evidence, describing what collaborative care is. I think having an external speaker also makes it seem more legitimate to centers, that this is someone else who's an expert from the outside coming to talk with us about this. I feel like sharing published articles that are good introductions to collaborative care in oncology is another way to increase awareness and buy-in. I included two there. And then the ACCC is working on resources, which you just got the QR code for, which also can help increase awareness at your centers. Increasing awareness is the first step of buy-in. People need to know what this is and what the advantages are in order to get them invested enough to think about doing a pilot of this. Next slide. I had talked about doing stakeholder-specific messaging. This is a slide from one of our first webinars that we did last year of different tailored messages that you would want to use with different groups, whether it's cancer center administration, the psychosocial clinicians, or the oncology care teams. You're going to get access to these slides, so I won't go over all of these. This is more of a resource. Next slide. With the stakeholder specific, I think for clinicians, it's also helpful to have conversations with people who are already practicing in this model. People have lots of ideas about what collaborative care might be, or how it might, what concerns or worries they might have. And I think there's nothing better than talking with someone who's already doing it, someone who's already having the experience of what it's like to practice in this model. Talk to someone else from that discipline to get their understanding. I think for administrators, it really is meeting with them individually to talk with them about it. The third webinar in the series is going to be a deep dive into this, of how do you sell this to administration. And I think we're going to invite some administrators about what the selling points were to them when this was pitched to them. Patients and families, I think, are really great partners for helping to gather support from a center. At Dana-Farber, where I was before Memorial Sloan Kettering, we presented to the Patient and Family Advisory Council, who really liked the idea that this was going to be systematic services for everybody, that this was a way to enhance current services, that this was a way to increase access, which are things that Patient and Family Advisory Councils are really important to them. And they often have leverage with cancer center administrators about what can be done. And then oncology clinicians, I feel like really, if it's hard for us as psychosocial people to know what this is, it's harder for them to know what this is at the beginning. So really provide broad strokes about increasing access. And as you get closer to launching your pilot, talk with them to help revise and get feedback about how to make it go smoothly. Next slide. Oh, I think that's, we already had that one. Next slide. And then after you have a decision that you're going to do a pilot, the communication around increasing awareness and buy-in doesn't stop. I feel like you need to put together a small team in order to manage this. And the focus of communication at this time is really getting everyone aligned to start the planning. People may have some idea of what is needing to be done and some buy-in, but may not have all of the picture. And so really working on making sure that everyone's aligned to manage people's anxiety and concerns. Sometimes people can get so anxious that they're not able to participate in planning. And so addressing those anxieties will help planning go smoothly. And knowing that this isn't something that happens quickly, that it does take months to plan a launch of doing something like this. I would say probably at least 6 months to do that, and to know that you'll have those 6 months to work through the issues to get to the plan for the launch. Uh, I'm going to turn it over to Jesse now.
Great, thanks, Bill. So I'm going to talk about the staffing and how we can start building a collaborative care team. I think there are a lot of kind of misconceptions around kind of what kind of roles you need and their responsibilities. So I always like to start and frame this as really optimizing interdisciplinary care. And I like to use the analogies of a wonderfully coordinated, chamber group, or even better yet, a jazz ensemble where, the whole is greater than the sum of its parts. But especially in a jazz ensemble, you get to have some innovation, some improvisation, and more individuation. But you still have to work very closely together to create, beautiful music, if you will. Next slide. A core principle of collaborative care, which again, reiterating what Bill said, is a system of delivery of care that allows you to provide evidence-based guideline level treatment, for distress. And when I say guideline level, I mean things like the ASCO clinical practice guidelines, the NCCN guidelines. These are all really well accepted guidelines, and collaborative care helps deliver these guidelines through allowing all of the people in the team to practice at the top of their scopes and work in a highly coordinated, non-redundant way, and that really supports each other as well as supporting the patient. Next slide. So this will this was covered in previous webinars, but just a reminder that collaborative care is a stepped care approach where we try to deliver the level of care to the patient that they need, and that involves the least burden and the least cost, but is effective. So, for example, people with minimal or mild distress. If you have a patient navigator that can provide resources to the patient and families that can address a lot of the practical needs, that can potentially help with dealing with some of the milder distress. But as you go up the ladder and get to more high or severe distress, then you may need specialty mental health care, psychiatry, psychology, and collaborative care provides that in a very efficient way through case reviews, and if possible, having someone available to also see patients either in person or remotely would be ideal. But the minimum would be to be able to have a psychiatrist and hopefully a psychologist as well to provide case consultation at your regular case reviews. Next slide. So I'm going to step through this quickly, but stop at the end where I kind of emphasize that the collaborative care model allows the oncologist, the care manager, which is typically a clinical social worker in the oncology setting, and the psychiatrist, APP, and/or psychologist to work together in a very coordinated way to serve the patient and their families and caregivers. And again, to emphasize that the key roles that you need for collaborative care is obviously you have your oncologist, you need a care manager, like a clinical social worker, and you also need a psychiatrist or APP to do the psychiatric case consultations, and preferably a psychologist if available as well, and to provide that case consultation, but also, if possible, be available to do evaluations and brief follow-ups as well. Next slide. So getting down to more detail about the roles, who do you need to get going with a collaborative care model? You need someone called a collaborative care implementation lead. That's typically someone who's a part of your collaborative care team. That can be, your psychiatrist. It can be your lead social worker, for example. It could be a couple of people working together. And I'll go into detail on all of these roles. You need an oncology champion, somebody in the oncology space who is going to help you communicate and advocate for this model, and to be the liaison between psychosocial care and oncology care. You need the care manager. The care manager is really the central hub for collaborative care. And through our experience, we've been doing collaborative care for over 15 years now at Fred Hutch, and we've helped a number of other centers launch their programs. So from our experience, we recommend about 1 to 1.5 FTE per 1,000 patients treated per year at a particular clinic. And I'll talk about the variables that go into what would be a kind of the sweet spot for your particular clinic. And a care manager typically in oncology would carry a caseload of about 30 to 60 distressed patients, people with clinically significant distress. In terms of psychiatry or APP, I would say the minimum would be a 0.1 FTE per 1 FTE of a care manager. And that person, as I mentioned, would do case reviews on a regular basis and provide some kind of as needed curbside consultation. Again, the ideal would be to have somebody available, preferably on site, but at least remotely, to actually do some evaluations for complex patients. And if you have that, then I think you would want about a 0.25 FTE or so per psychiatry consultant. And then ideally, and I have this under aspirational, it would be great to have a patient navigator. It would be great to have clinical psychology. It'd be great to have palliative care provider as part of your team. And it would be great to have a psychiatric nurse. These are not absolutely required for an initial pilot, but maybe something to move towards. And it's very helpful, and studies have shown that having an implementation coach who has kind of gone through this process, who has successfully launched a program to help you kind of get through your implementation process is potentially very helpful for your launch. And at the very least, as Dr. Pirl mentioned, it's helpful to have somebody who's been successfully able to launch this to maybe help you kind of sell it at your center, maybe do a grand rounds, etc. Next slide. So let's see. Talking about the roles. Let's see. Looking at the population served. Oh yeah. Okay. So this is what might help you kind of decide, and where in the range of FTE you're going to need, and what goes into the sweet spot of what FTE you're going to have. So the population that you serve, the higher you're going to need higher FTE for more complex populations. So, for example, at our center, we have a lot of people going through stem cell transplant. Those are very intensive treatments, and we need more FTE for those to help those patients. Also, if your center also serves a lot of people, survivors who are, several years out, then you're going to need more FTE. If you're going to serve a lot of complex psychosocial needs, then that's going to also play into your FTE needs. In terms of psychosocial conditions treated, you will want to decide, what kind of conditions you're going to want to treat. For example, are you going to treat substance use issues? Are you going to treat people with serious mental illness like, schizophrenia who are going through cancer treatment, or are you going to refer out to other mental health clinics for that? In terms of the psychosocial interventions, are you going to be providing, specific interventions for, things like PTSD or, severe personality disorders, or are you going to refer out? And of course, this also depends on what services and resources are available to you, both within your institution and also in the community. So if you have good supportive services that you can refer to, then that's going to, of course, help in terms of your staffing. If you're in a remote, rural area that doesn't have a lot of community resources, then that's going to also play into your decision making. And of course, in terms of your provider responsibilities, are you also, if you're in an academic center, are you going to be also doing a lot of teaching and research, or are you also going to be covering inpatient units, things like that? So obviously a lot of variables that go into your staffing, but these are hopefully helpful to let you think about what you're going to need. Next slide. So let's talk about each role very quickly, individually, and hopefully this will be helpful. I'm going to focus on the characteristics and responsibilities of each role. So the implementation lead, again, this is not a separate person. This is typically a person who's in your collaborative care team. I was the implementation lead in collaboration with our lead clinical social worker when we launched our program. And so this person is really someone who is really passionate about practice change and delivering comprehensive psychosocial care through this collaborative care model. Someone who's really mission driven and in it for the long haul, because there's going to be bumps in the road, and you don't want somebody who's easily going to give up easily. Somebody who really understands and appreciates the importance of each role in the collaborative care model. There's no one role that's not important. Everyone is important, and everyone needs to have the resources that they need to do their job. So someone who has the ear and support of clinic leadership, who can really work with staff like the schedulers, the front desk staff, et cetera, who can really collaborate with everyone involved to make this work as a team. And someone who's interested in collecting data. Data, as we'll talk about in future webinars, is critical in both launching and also sustaining a collaborative care program. And someone who can really work with and understand and articulate collaborative care to different folks in the clinic, including clinic leadership. Next slide. So the oncology champion typically is an oncologist who preferably is in some sort of leadership role in oncology. They don't have to be, but someone who is respected by their fellow oncology providers, who's willing to really advocate and educate their fellow oncology colleagues about the importance of psychosocial care and collaborative care, someone who's willing to help and partner with you to overcome challenges and barriers, and also to help collect data and metrics. And so this person is really a key liaison between the psychosocial team and the oncology team, and a key advocate. Um, it doesn't take a lot of time. It just takes someone who's really passionate about the importance of psychosocial oncology. Next slide. The care manager, obviously a critical role here, typically a clinical social worker, but can also be a nurse or a psychologist or a licensed mental health counselor, just somebody with behavioral health expertise and training. It's ideally somebody who has some space in the clinic, so that they can kind of be close to the oncology teams. Someone who's really skilled at establishing rapport and conducting, comprehensive psychosocial evaluations and safety assessments. These are obviously, core, clinical skills that any, psychosocial oncology provider should have. But a care manager is someone who's comfortable with collaborating with not just other psychosocial providers, but other providers in different supportive care disciplines, as well as very importantly, someone who's comfortable communicating with the oncology teams as well. And of course, we collaborative care is based on evidence-based care. It's based on measurement-based care. So someone who's really interested in providing evidence-based care and treat patients towards a target of hopefully treatment response and remission. And then Courtney will talk about, some core understanding of psychotropic medications as well. Next slide. So the psychiatric consultant, it can be an MD, DO, or an APP, is important in providing case consultation, typically once a week or once every 2 weeks to any given care manager. This is someone ideally who has specialty training in treating people with cancer and also other medical conditions. Of course, people with cancer have all sorts of different medical problems as well, typically. Someone who has a real passion for multidisciplinary collaboration. And this is not, you'd think this would be a given for any psychiatrist, but not necessarily. So someone who really likes to work within a team, who's a strong communicator and educator. Very importantly, someone who's able to quickly synthesize data and formulate treatment recommendations. And we'll talk more in future webinars about the case review process and how that goes. But this is a skill that can be learned, but is an important one. And of course, someone similarly, as I mentioned before, is really interested in evidence-based care and is willing and available to do, curbside consultations as needed, wants to be available and help out whenever possible. And if possible, be available to do the occasional psychiatric evaluation and follow up for more complex cases as well. Next slide. And then finally, I'll just talk about kind of aspirational folks who I think it would be very helpful. We have about a dozen patient navigators at Fred Hutch who really help to offload a lot of the kind of practical needs and navigational needs of patients so that our clinical social workers can really focus on the clinical aspects of their roles. Doesn't mean that our social workers don't do some of this navigational work, but they can focus their majority of their time on what they want to do, which is the clinical work. A clinical psychologist is wonderful to have if you can have them to really provide. We have our clinical psychologists attend our case reviews as well to provide specialized behavioral strategies, recommendations for our patients, and also be available for specialty consultation and follow-up for things like complex, PTSD, substance use, chronic, suicidal ideation, personality disorders, etc. Um, uh, Dr. Pirl will and Courtney will talk more about having palliative care as a part of the collaborative care team. I think it's a wonderful addition and innovative addition to the collaborative care model. It's just one example of how the model can be flexible and can be expanded to other overlapping conditions and disciplines. Having a clinical nurse coordinator, I've found is helpful if you can have one to really help support the collaborative care team in a number of ways. You can see here a number of ways that they support our team, including helping with crises and check-ins for new medications and things like that. So very, very helpful to have a nurse if you can have one eventually. It's taken us time to add these components, so please don't feel like you need to have these all at once. But maybe things to think about. And then again, having an implementation coach that can help kind of launch your implementation and also set you up for sustainability once you have launched it, I think can be really helpful and ideal if you can have access to that. All right, I'm going to stop here and turn it over to Courtney.
Thanks, Jesse, and thanks, Bill. Hi, everyone. I am pleased to be here with all of you and share with you a little bit about how we've implemented collaborative care at Dana-Farber. And I think, Sydney, you can go to the next slide. Great. So I was thinking a lot about how we might be able to best kind of share what would be helpful at considering a piloting collaborative care. But I thought it was important to share maybe recommendations for where to start through kind of the lens of what we've learned at Dana-Farber over the last 5 years and using that great gift of 2020 hindsight. So I hope this will help you, create your roadmap for a pilot, but also help you think about how you might be able to set yourself up for success for expansion when you're ready to move out of the pilot phase. So just for context, between 2020 and 2023, Dana-Farber launched collaborative care, or what we call supportive oncology collaborative, because we've added palliative care to that team. We did that in one of our regional campus sites kind of per year. And this was a small team, the Trailblazers. They really had similar providers. They really worked hard on developing the program, developing the workflows, creating systems and working together as an interdisciplinary team, and created trainings over time. And because of the success of that pilot in that team, in 2024, our department made the decision to make collaborative care or supportive oncology collaborative the standard of practice for all of our ambulatory care. And so you'll see on the timeline, if we fast forward to 2024 and 2025, we really needed to be able to create a plan for rapid implementation, training multiple collaboration teams, and focusing on the fidelity of the model. Next slide. We, at Dana-Farber, the oncology social workers are really the primary mental health providers. and the, dare I say, the foundation of the model. And we are a very large team. So one of the first steps that we had to make as a team, leadership team really, is we needed to be able to create the infrastructure to ensure our team had clarity, had time, and the training they needed to be successful in the support of oncology collaborative model. So we really started creating some of the infrastructure to do this large scale practice change. We created a manual, we created a training timeline so that we knew, when do managers need to be trained and when do staff need to start be training. We really tried to standardize as much as we could about what are the clinical components and what are the clinical competencies that we need. And then we did develop a multi-pronged training program. Next slide. And this is a screenshot of just the table of contents of our training manual, and it really is our roadmap. And what we think of is that we wanted every social worker to really have the same information and how we were thinking about, talking about, and applying collaborative care. And so I'll just go through a couple examples from this table of contents in the next slides. So one of the examples that we really spent some time is really defining and clarifying what are the core clinical components of an oncology social work in our supportive oncology collaborative model. That way each social worker was kind of aligned in their approach to patient care and working with patients and families and how they were functioning within the SOC. So we standardize things like screening and safety and what does the psychosocial assessment need to have in working with other multidisciplinary providers. We also spent a lot of time about how are we thinking about developing goals for our patients and our families, and how are we thinking about care planning differently or maybe similarly. And then we also about communication, both with patients and families, but also with each other, and how we make sure that those weekly meetings are really as effective as possible. And lastly, we really talked about what are the evidence-based interventions that we think are the most important for the problems and the things that we addressed in supportive oncology, and how do we make sure that all of our patients are having serious illness conversations. Next slide. We then really tried to think about what are all the different things, process and clinical, that we need to train our team on, and and really make sure that we were creating enough time for our social workers to really feel that they weren't kind of being rushed into the system, but were being kind of phased in. So we really took a phased approach where we thought about, we need time for just exposure. We need time for learning, to reading those articles, to seeing it in action, maybe to talking with other social workers who are already doing the model. And then we move into the actual live active training. And many of the trainings that we have were created by the pilot team and the social workers. Bill, I know, recorded a pharmacology for non-prescribers video. We have our social workers shadowing our palliative care colleagues, and they're talking about how are we going to collaborate on serious illness conversations. Then we really try to skill build. So we have our social workers really practicing, and this is where our peer mentors come in to really help support, practicing the conceptualization and the presentations. And then the last phase is really just integration of the skills into their clinical practice and building that multidisciplinary team. Next slide. When we were thinking about clinical competencies for oncology social work in support of oncology, we really wanted to be clear about many of these skills we are already doing in our work. But I think it was very helpful for us to kind of really put on paper or kind of put thought into about what are some of the things that we want to ensure that all of our clinicians are competent in, feel confident in, and have some training in. And because we added palliative care to our program, we also need to think about how we're preparing our social workers to be able to both assess and intervene on behavioral management of pain and symptoms and serious illness and goals of care. And so this really then led to, next slide, to our creating an education and training program. And what I will say, I think the first two bullets are probably the most important bullets on this slide. I think, what we found at Dana-Farber is we really had to think about and normalize and destigmatize different skill levels and different evidence-based interventions. We really wanted to create a safe, place and supportive space for staff to be really explore that for themselves. Like where do I feel confident and where do I think I might need or benefit from some additional skill building or training or learning? And after that occurred, then we really tried to create some individualized training plans. So sometimes these are, external training. There's so much out there in the world that's available. We also created some internal trainings. We were really fortunate to have a psychologist who trains on behavioral management of pain through CBT. And I also think that we sometimes dismiss case consultation and coaching in our learning and training. And I think that also is a really important part of the process. And then lastly, not lastly, sorry, honestly, one of the most important things that I think that we have recently started is our peer mentor program. And I'll talk a little bit more about that. But that's really where those social workers who are in their regional pilots who learned so much through that have really been able to mentor the newer social workers that are coming to into SOC. And then I really have been thinking a lot as a leader of the division of like, how do I ensure that the division-wide education program is also supporting the needs in supportive oncology? Next slide. So I'm going to take us back in time and go back to 2020 and kind of try to summarize what I think might, looking at that 2020 hindsight, what I think might be really important for all of you to be thinking if you're just starting collaborative care in your organization. Next slide. I think, when you're getting started, I think thinking about standardization is really important. And I mean standardization and not rigidity. I think it's important to really think together as an interdisciplinary team. How are we going to talk about collaborative care, just as Bill said in his talk about how we're going to talk to other clinicians and other people, but how are we going to introduce patients to the model? I think we really took a look at our psychosocial assessment and case presentation template because what we found is we really needed to include psychiatry and palliative care in the process because in the model, oftentimes that psychosocial assessment that social workers are doing are actually giving information to the other providers to make recommendations when they're not actually seeing the patient themselves. And so we just had to tweak a few things that really helped that occur in the weekly meetings. And then I do think it's helpful, and not only helpful, but I think it also helps with the change, kind of people thinking about themselves in this role to like really kind of list out the clinical components because I think it helps people say, oh, these are things that I'm probably already doing in my practice, and it's not me doing something new or learning something new, just a new way of formulating it and putting it into practice. Next slide. If I were to think about like top 5 training things that I would recommend just making sure your team has general knowledge about the purpose and goals and of collaborative care and kind of dispelling any myths about that. I know we spent a lot of time with thinking about how do clinicians who are maybe not used to using validated tools enter that into their and really integrate that into their clinical practice, but not only their practice, their case formulation and how they're thinking about their patient's progression over time. Like Jesse said, I think it's really helpful for social workers to have a basic understanding of psychopharmacology because oftentimes, just like when we're talking with our patients about their medical recommendations, we're often really reinforcing those, providing education and helping this patient feel, kind of monitor if this is working for me or not. And the last 2 bullets, I think, is something that we often do when we're working independently with our patients and families and in our own kind of case, like, again, thinking about our cases, talking with our patients about the goals and what we're thinking. But there is something different about being able to kind of do that in individual work and then present that to a group to then, and I think it's really helpful just to practice how do you provide clear, concise case presentations and what is your, question to the team so you can get out most of what you need from that weekly meeting. Okay, next slide. I am a mindset that we all should have growth mindset and that we should always think about how we're refreshing our clinical skills. So we did some of that work with our team. I was like, let's all kind of get back to the books and think about CBT for anxiety and depression. Let's do some skill building training. Let's thinking about, behavioral activation and motivation interviewing. I think these three things are probably some of the top interventions for the problems and the situations that we see in collaborative care. Not a list. I'm just trying to give you like a few to start with. We also found it very helpful to have a few departmental psychology tool subscriptions for clinicians to help them have some concrete tools and resources to integrate into their clinical practice with patients. Okay, next slide. So this is my last slide, and this is kind of my parting thoughts about what you might think of when you're piloting collaborative care. And I put that first bullet there for a very purposeful, because I think thinking about 2020 hindsight, I think the really important thing is to really focus on building relationships between the interdisciplinary team members. We now at Dana-Farber have really, we don't launch a new team unless we have an in-person retreat with all of the team members to help build relationships before we launch. And these retreats are really like, we do some getting to know you questions. We have a psychiatrist who loves improv and puts the team through improv. I still have visions of that. And they practice team meetings together. And I think laughing together, they become more connected, they build trust, and allows them to kind of step into those weekly meetings as like, we're a team, we're in it together. I think you should expect resistance. We are human beings. We all resist change in so many different ways. And I think you should give time for your team to really work through that. And if you don't, I think that's the time to feel pressured. It kind of makes the team feel pressured or can increase resistance. And that going said, I think it's really important to invite staff to share their concerns and talk about their worst case scenarios, and then talk together how let's ensure we're not going to let that happen. And then I think the next two bullets, I think there is something about supportive oncology collaboratives is both beautiful and can be vulnerable about sharing and being transparent about the work you're doing with your patients and kind of how you're thinking about cases, what you might recommend. And I see this from all of the disciplines, not just social work. And so I think it's really important for the team to acknowledge and support each other in this vulnerability, and really to create a safe space to be talking about, what we all have, our clinical areas of growth or cases that we feel really stuck with. I think my team at Dana-Farber is probably sick of me saying, is anybody writing this down? Because I really recommend you document whatever you have, start documenting it in one place, whether it's going to get changed or, redlined. It's really important to have that roadmap from the very beginning. And then lastly, I would say, I think there is a lot of myths about collaborative care out there. And I know when I first was getting exposed to the collaborative care model when I joined Dana-Farber, I had to do my own learning. And I actually reached out to Jesse and I spent some time with him. And I think it's really important, if you're thinking about implementation, to talk with people who have actually implemented it and how their experiences was and what did and didn't happen. I know I'll be at APOS presenting some of the work that we've done, and I have a social worker team who's going to be presenting on our peer mentor program at AOSW. So I think really reach out and connect with the people who have can help. And that's my talk.
Thank you, Courtney. We just also want to point out that there are a number of general collaborative care resources to Courtney's point, that where you can learn more about this evidence base, where you can utilize the tools and techniques that come from this. So we've included those QR codes here, and they will be included in the PowerPoint once that is distributed as well. So from this, we also want to say thank you and open this up to questions. We will put links to the upcoming webinars in the chat so that you're able to register now for webinar 2, as well as the office hours, and then the next webinars in succession. So thus far, I only see one question, two questions that have come in through the Q&A session. So the first one is, I would love to hear how you layer integrative oncology as intervention modalities in collaborative care program beyond distress screening phase. How does your service balance between offering integrative oncology options and traditional supportive care?
I could take a stab at take a stab at that one. So in collaborative care, it really isn't developing kind of automated referrals based on distress screening, that these things go to these services based on the way they filled out certain questionnaires. It really is clinical decision making in the team meetings that patients enter the collaborative care service model through either screening or referrals. They get evaluated by the clinical social worker, who's the care manager, and then discussed at the team for what services do we have would be the best for what the patient is experiencing. And so you can think of all the things you have available in your center and how to formulate where to put them in your steps of care about what things may work for certain patients in certain situations. And so it's actually a really nice way of ensuring that patients are getting the services that you have available that may benefit them the most. And so it's really not layering, it's incorporating the services into the armamentarium that will be discussed in the team meetings, the case reviews, kind of similar to oncology tumor boards where they're figuring out what modalities of care to give. That's what's happening in the case reviews of, of, of doing that. Does anyone have anything to add to that panel?
Yeah, I totally agree. It's collaborative care is not formulaic, and the case reviews are really the place where, as a team, there's a discussion, a very efficient discussion that targets the patient to whatever intervention is needed. And each provider has their specific skill bases and interests, and sometimes the discussion might say, hey, I think let's consult with this person who has a lot of expertise in PTSD, and let's see what they have to say about it, and things like that. But as Courtney said, there's some core competencies that everybody in collaborative care should have, and those will serve a lot of patients. But every patient's different, every problem's different, and we don't want to be formulaic about it.
There's a lot more questions. Bill, do you want to take a stab at the next one on there?
I'm going back to the questions to look at the next
I can
question.
read it for you. From my understanding, collaborative care model has a monthly limit of 180 minutes and typically lasts 6 to 9 months. If a patient remains in the collaborative care for a year, is that because they've surpassed the expected timeline? Do they need to be referred out? Blah, blah, blah. So this is kind of brings in billing versus the model of care. So someone wants to speak to that.
Yeah, so I think this is a billing issue, and I feel like at least centers where I've worked, uh, we try to deliver the care that patients need, regardless of billing, or find ways around the billing piece. So I feel like you may reach the limit of billing, but that doesn't necessarily mean that care is over. Um, so that's
Great,
probably the best way I can answer that.
great. And then the next question, I'm just going to keep going if you guys are okay with that. We do some research about professional identity threat when integrating mental and behavioral health care into primary care and cancer care settings, because I've noticed clinically that some professionals can get a little protective around their typical roles depending on their education, history in other settings, history in the current setting, and biases. To what degree do you consider these culture shifts in new roles on the care team and assigning task roles and shift and role sharing?
I can take a stab at that. These are roles that are not necessarily familiar to everybody. I'm a psychiatrist, and I can tell you that in my psychiatry training, I was not trained in doing the type of case consultation that collaborative care provides. But I can also say that I personally love this role. I love interacting with the team. I'm not somebody who likes to sit in an office and see patients by myself all day and not interact with my colleagues. So I would say that there's probably some similar kind of feelings around, from social workers and psychologists. And so, collaborative care, just like any model of care, is a specific model, and it's not for everyone. It's for people who really want to work within a team, and but for those who do want to work within a team and not, be kind of isolated and want to keep learning. I'm still learning. I learn from everyone I work with. This is a great model to work within. So,
And I feel talking with people in the role is really helpful in that. And like if, say, a psychiatrist is anxious about or concerned about their role in this model, talking to a psychiatrist already practicing in that model. Same with social work. That I feel really learning more about what the roles are and how it, in my opinion, it really establishes everyone as having a seat at the table in a meaningful way that we don't kind of experience in the traditional model, where there often is more turf stuff and yeah.
Well,
Yeah,
thank you.
I would agree with that. Just quickly, I agree with that. I think what you have to do is just talk about it and get it on the team. We've done some work about role clarity, and I will say most of the team that, and once they kind of get over the kind of anxiety producing of what does this mean, they really feel connected, and we're like, they don't have to worry alone, and they have other people to really manage these complex cases that we all see in our cancer centers. So sorry, Krista.
There are so many great questions. We will take these questions and put them in the next webinar. And we also have the office hours, which I think will be perfect for this sort of dialogue. Thank you so much to everyone for being here today and to our hosts and ACCC for hosting. Thank you.